Hello, I am Professor Dr. Manish Gupta. The case I am showing here is in external canal osteoma being excised. As you can see, it's an irregular bony outgrowth at the cartilaginous bony junction, sessile and benign. And this is an intra-op video now showing an postaural approach where we have done a myototomy and 6 o'clock, 12 o'clock incision being given, the posterior canal wall flap being elevated, and the osteoma was completely blocking the canal, and there was some complaint of ear discharge, blockage, hearing loss in this patient. It is often differentiated from an exostosis because exostosis often presents with similar complaints, but it is multiple, bilateral, smooth, without deep extension. So in this we plan to raise this flap and do drilling at the base of the attachment of the osteoma and along the posterior external canal wall. So in this way we get a plane to excise the osteoma completely without damage to the overlying skin and periosteum. So in this way it was avoided for any split thickness skin graft is not needed in this patient, neither any raw area was left behind. Some amount of drilling of the osteoma itself may be required to get a good exposure inside. It is important to follow the landmarks as we just follow the external canal. You can see I have placed an aluminum foil from a suture so as to protect the posterior canal wall, skin and periosteum. Now detaching this osteoma at the 6 o'clock, 12 o'clock also, so that we can remove it. This eggshell thinned out can be removed. The large lesions of the osteoma like this are often associated with earwax, debris or secondary cholesteatoma. Same was in our case. See, now there is a small glimpse of the canal wall. Intermittently the curette was used so as to avoid direct damage or hitting the burr onto the external canal wall flap. After thinning the overlying osteoma, it can be removed like this, raising the flap. It was sent for histopathology, which suggested a laminated cancellous bone surrounding fibrovascular channels with minimal osteocytes. While exostosis will have shown concentric layers of subperiosteal bone with abundant osteocytes. Further drilling away the bone. See, now as the final bone chip of the osteoma being removed with the help of a curette. If you would have approached the osteoma from its peak, then saving this flap would have been difficult. As the osteoma was large, so we couldn't approach it transmedially. See, there is a lot of granulations as we try to raise this flap and bring it back posteriorly. There are a lot of adhesions, granulations, and once we have cut these adhesions with the microscopic scissors, there was canal cholestoma. And as per the classification given by Nam et al., it was a stage 2 canal cholestoma with no bony destruction of the canal wall. It was removed completely, and any keratin debris sticking onto the canal wall was also removed. The tympanic membrane was found to be intact, so there was no need for any tympanoplasty in this patient. See, this is the view of the normal tympanic membrane. Few keratin debris still adhering onto the canal wall were removed, scraped off, sent for histopathology. Medicated wicks were placed in the canal to keep the flap in position with the bony wall. And patient is under follow-up with no recurrence in last 6 months. Thank you for watching.